Hello, my name is Jim Capretta. I'm a senior fellow at the American Enterprise Institute, and I'm very pleased to welcome you to today's virtual event on the promotion of high-value managed care plans to lower costs and improve quality for American consumers and patients. There have been many attempts in recent years to inject more cost and quality discipline into U.S. healthcare, but none have yet delivered fully satisfactory results. The problem is not the failure of managed care as a concept per se. In the right context, the organized use of cost and quality data to continuously improve the efficiency and value of the services provided to patients has been shown in countless studies to produce better results than a dominant but fragmented fee-for-service system. The challenge has been in scaling the right models to achieve large system-wide beneficial effects. During this event, we will talk with two authors of a recent plan to jumpstart more widespread enrollment in high-value managed care. Their initiative, the Better Care Plan, recommends migration into better care teams to promote and strengthen the role of the best managed care plans in U.S. healthcare. Better care teams is the label that they put on it, but one could read for that high quality managed care too, of various types of labels. After I introduce our two guests, which I will do in just a minute, they will each have an opportunity to make introductory comments, and then I will engage them in a conversation. With about 5 minutes left, I will turn to a small number of audience questions we have received during the course of the event and pose them to our guests, if we get any. For those viewing live, therefore, if you would like to submit a question, you have two options. You can send your questions by email to jack.rowing, R-O-W-I-N-G, @aei.org, or alternatively, you can send your questions to Jack via Twitter, I guess X as it's now called, using the hashtag AskAEIHealth. You can also find Jack's email on the webpage for this event. Okay, now to our guests who have graciously agreed to participate in this today. First, I'd like to introduce Congressman Allyson Schwartz, a Democrat who represented Pennsylvania's 13th congressional district for a decade, from 2005 to 2015. During her time in Congress, she was a leader on healthcare issues as a senior member of the Budget and Ways and Means committees. She was chair of health for the moderate New Democratic Coalition, which was a group of Democratic Congresspeople then and also now, and played a prominent role during the development and passage of the Affordable Care Act, which took place in 2009 and 10. She was also involved with numerous other significant health policies that were considered by Congress during that period. After leaving Congress, Congresswoman Schwartz served as president and CEO of the Better Medicare Alliance, where she advocated for improving Medicare through policies promoting cost-effective Medicare Advantage plans, which of course, by and large, are managed care plans. She is now a senior advisor to FTI Consulting. Following Dr. Schwartz making introductory comments, we will turn to Dr. Gail Wilensky, another longtime leader in the health policy world. She served as CMS administrator, that is, then it was, of course, known as the Healthcare Financing Administration, now known as the Centers for Medicare and Medicaid Services, during the presidency of George H.W. Bush, and then as also a senior advisor to the president in the White House. She is also a former chair of the Medicare Payment Advisory Commission. She's a senior fellow at Project Hope and a prolific author of commentaries on health policy, many of which have been published over the years in the New England Journal of Medicine and other health policy outlets. So without further ado, let me turn first to Congresswoman Schwartz to say whatever she'd like to say about this initiative that she's associated with. By the way, I should also note that there were several other authors on it. I think a total of 8, if I remember right. And so there are several other very prominent and high-profile people associated with the plan as well. So Congresswoman Schwartz, you proceed as you'd like, and then we'll turn to Dr. Wilensky.
Okay. Thank you, Jim, and thank you for hosting us and giving us another venue to talk about this paper. I should mention that it was published in Health Affairs Scholar. It's a new publication by Health Affairs in their launch edition back in June 2023. So we've gotten some very good response to it. It certainly has a bold title. It talks about better care, the Better Care Plan, a blueprint for improving America's healthcare system. We're not the first people who wanted to try and do this. That's written about a good bit. And just to say, in my own career as an elected official, previously having worked in the healthcare sector as an executive, really my goal always has been to improve access, to improve delivery of care and quality, which doesn't get talked about as much as access and affordability. But all that package together is something we're still working on as a part of all sorts of healthcare policy. So we thought this was very timely because we came up with a couple of good ideas. We're a group, by the way, the 8 of us, there's 8 to 10 of us who meet every other Friday and talk about healthcare policy and talk about what's being done, what's happening in the marketplace, what's happening in public programs, and what we could do better. So what we wanted to do and what we realized and what we articulated in this paper is that as we see it, fee-for-service payment is fragmented. Kind of mentioned that. It is expensive and it is highly variable in terms of the quality. So how do we fix that? So we started with, we need to change the way we deliver care. We need to change how we pay for it. And we need to measure and report care, the quality of the care that's provided. We'll talk about many of the specifics, but I'll just say a couple of things about it. We really seem, as you suggested, we believe that a team-based approach centered around primary care is a basis of good quality care. And you need to manage all those subspecialists. To do that, you really need to change the financial incentives for the way we pay providers, which is to move away from fee-for-service, which does a pretty good job, not great all the time, in terms of in episodes of care, but in terms of encouraging managed care, encouraging care coordination, encouraging continuous treatment for people with chronic conditions, which is where we spend most of our money in healthcare. It doesn't do as good a job. So we need to change that to a risk-based prospective payment to providers. So we talk about that. We talk about what it means to be team-based care, set out principles. We talk about how you can move towards and should move to more. It's actually not, you're right, it's not like we're not doing this now, but we're not doing it broadly enough across the healthcare system. So we want to see more of that payment change in Medicare and Medicaid under the ACA exchanges, and actually in the private sector commercial coverage as well. And so two big ideas here. We also is that they would be created an entity that would certify the better care plans, which providers, which insurers are actually doing this, and they meet the elements that we and principles that we describe, in order to enable purchasers, whether it's the government or whether it's employers or whether it's insurers, to know what they are. Right now, we don't have an easy definition, or we don't have a consistent definition across the country or across programs. And so we have to make it easier for purchasers to know what they're buying. And we think that that can grow managed care in this way in the private sector. For employers, we've been talking about that, and I'm sure that Gail will talk more about it. So let me just close there and saying we are interested in the competitive market, kind of, so that people can make choices, but you can't make choices if you don't really know what you're buying and are paying for. So that's where we set out. It's gotten some interest around, and we are moving forward and trying to encourage more people to understand it, know about it, and to support our effort. So anyone listening who says, I'm all for this, how can I be helpful? My organization or I myself want to be able to be helpful, by all means, be in touch with us. But let me leave it there, because I think it's kind of the really good ideas in the way that we can move forward in ensuring improved quality. And I think Gail may talk more about the quality and patient safety pieces too, sharing data, making sure you report quality, making sure that you monitor that quality. And then again, purchasers and patients understand and how to buy and choose quality care. So I'll leave with that and look forward to the rest of the conversation and your questions.
Thank you. Dr. Wilensky, please proceed.
Thank you, Jim. Allyson has indicated the main outline of the proposal and the important points that distinguish it from some of the current delivery models. I want to go back and again try to help people understand what it is that's different about what we're proposing. For one thing, a lot of the focus for the past decade or more has been on reducing the number of uninsured, and secondarily about spending in healthcare and the importance of slowing down the rate of growth. We don't question the key role of either of those issues. Getting coverage for everyone is part and parcel of the Better Care plan that we have proposed, and trying to find ways to sensibly slow down the growth in spending in healthcare while improving the quality of the delivery is also embedded in our model. So I want to make clear that although we have tended to focus more on the processes of care, we don't in any way question the importance of these other two factors that have typically gotten the most attention. But what we have noted is that while the number of uninsured and the rate of spending remain issues, equally or perhaps even more important is the importance of the processes of care that are used to deliver care in the country. We all had an opportunity to see firsthand, up close and personal, the failures of the fee-for-service system during the pandemic. It not only showed the problems that have been known about fee-for-service, which is the discontinuity in care that is presented both for the providers of care, physicians, hospital providers, nurses, etc., other clinicians, but also for the patient, and the fact that fee-for-service emphasizes more care as opposed to better, higher value care. What we also saw during the pandemic period was how dangerous reliance on fee-for-service is for the financial well-being of the providers of healthcare services. Physicians in particular, whose offices were directly affected during the pandemic, saw up close and personal, as they say, what happens when you rely on a use-based system to generate revenue, as opposed to having a known prospective payment of the way that Medicare adopted in the mid-1980s, prospective payment initially for hospital inpatient, then prospective payment for hospital outpatient, followed by a prospective payment system not quite as developed for both skilled nursing facilities and home care, but fundamentally different from the unfortunate incentives built into fee-for-service when it comes to the physicians and clinicians providing care, where the more and the more complex services you provide, the more you are reimbursed, as opposed to rewarding quality, appropriateness of care, improved health and well-being of the patient. And it was really on trying to focus away from that, where we have spent our time But even more so than the financial aspects is also these processes of care that are adopted, that the delivery of care in a world that is spending 17 to 18% of our GDP, that is what we spend roughly on healthcare. We need to find a way to encourage and reward those groups that are providing improved and more efficient care, higher quality care. As was indicated, the team-based focus is what we have designated as the best way to provide care. There's also much more emphasis on continuous quality improvement. George Halverson, one of the members of our group, has made that, if not a life passion, a major current passion in terms of improving the delivery of better quality care. And that in doing so, you have a lot of repercussions on what it means to deliver the kind of quality of care that we think is appropriate in a country like the United States, which again spends so much, but has traditionally not had the kind of outcome measures that we would like to have. People, of course, have to understand that health and improved health outcomes only really secondarily depends on the delivery of healthcare. It is so much more a function of the social determinants of care, the circumstances in which people live, do have their earnings occur, etc. But where we spend as much money as we do on the delivery of healthcare, we need to find a way to improve what it is that we receive. And our belief, this is a group of people who cross backgrounds politically and in terms of their own backgrounds, medically, economically, as we just heard from members of Congress. That has helped us to try to think in a broad way about what it would take to transform what we do in healthcare to one in which we focus on better outcomes and a more efficient delivery system. We don't promise that it will solve all of the problems we face in healthcare. It won't, but we think the real difference has been the focus on the delivery of care and continuous quality improvement, and that will help lead to a more value-based care, both for those providing care and for those receiving care. Easy to say, very hard to do and accomplish in our current healthcare delivery system because of all the reasons that the three of us have discussed in the past. Thanks. Thank you, Dr.
Wilensky. That's both of you. That's a terrific introduction into this very complex topic. So to make it even more complicated, I want to try to connect a couple of dots here for a couple of minutes, and then we'll jump into a couple of questions that follow from it. One is that for those, many of the viewers probably know this, certainly our guests know this, that Dr. Paul Elwood was a big champion of the sort of first versions of managed care in the United States, and the value proposition that was just highlighted of getting a population-based payment that would allow providers working with the payers to essentially invest in trying to keep people as healthy as possible, which is very hard to do in a fee-for-service system that rewards volume of procedures. That is, for sick people needing something, the provider system actually generates revenue from providing, higher volume of those kinds of procedures. So the whole theory behind managed care has always been, you get the money up front and try to invest in it through primary care, as both of you said. value, keep people as healthy as possible. Of course, everybody's going to need services when things go wrong, but you try to minimize it through more upfront investments. So that was the real driving force behind Dr. Elwood's push in the early 1970s to put into federal law maybe what we could call the precursor to better care teams, which was the HMO Act, which had essentially the same theory behind it, which was to try to break through some of the regulatory and system clutter that's out there and sort of say, here's a good managed care plan. Purchasers, that is employers, take it up. And so they tried to promote the HMOs by giving them sort of ready access to the employer-based system through a certification process, not unlike, I think, from the paper, what might be envisioned for the team-based care and managed care systems you're thinking about here. And I'm wondering what you think about that. Is that, where are we with this managed care in the United States? We've been at it now for, half a century, essentially. How do you see your idea fitting in with sort of where we've been and where we might be going?
Well, I guess I could start by saying, look, we've made a lot of progress and learned a lot in the last 20 years, 30 years, more than that, in terms of what this really means and how it really works and how you can incentivize this behavior. I mean, I guess the biggest example is Medicare Advantage. And look, it's still heavily regulated. It's not like you said, just go ahead and do your thing in terms of making the changes that what kinds of benefits you have to include. Probably that was in the HMO Act too, but also expecting quality and getting data and getting those measurements and making them public. The star rating system was really, I think, a huge change. There are a couple of big changes, huge change for those who are doing Medicare Advantage, the providers and the payers, and the fact that we've seen the results of that, which is fewer admissions to the hospital, fewer avoidable admissions, fewer readmissions, better outcomes. But we've also learned is that you do have to pay attention, as Gail brought up, to the social risk factors. That without understanding that the healthcare system was not, you might make a referral, you might say something about, oh, you're hungry, you need to, there are services you might be able to get for that. But do understanding that more care in the home makes a difference. Again, team-based care, bringing in counselors, bringing in navigators, bringing in health coaches, being able to help people do what the doctor might recommend or the clinician might recommend, supporting that effort, understanding that food insecurity, that housing, that early intervention, which was one of the early ideas of HMOs, which is get people in earlier. I was just in a meeting this week about obesity. Well, it's not just about obesity, it's about the diabetes and the cardiac conditions and hypertension and all that can come, negative things that can come if you don't treat it early. So I think there's been, what's interesting about the last few years is people have been moving into the beneficiaries of public programs have been moving in this direction. They actually like it. They like managed care. They like the care coordination. Yes, there are issues about denials, but you get that now in fee-for-service as well. There are issues about networks, but increasingly plans are providing care that responds to consumer behavior because it's quite a competitive system. If you're not doing well, somebody goes to another MA plan. It's and greater recognition, of course, about disparities in delivery of care, disparities and attention to inequities and discrimination, and the need to attend to those as well is really important. So you're seeing recent changes and adding social risk factors to star ratings, encouraging that kind of the supplemental benefits. Turns out that matters. It's not just dental, vision, and hearing, which are no small benefits. They're big benefits. And affordability in terms of zero premium plans have made a huge difference. I'll mention just two others. Almost it's like 80% of people who are in Medicare, Medicaid across the country are in managed care plans. Some of them use prospective payments to providers, some don't. So that's the question, is how can we encourage more of them to do that? And secondly, we have MACRA, which you all remember, Jim, came certainly from, because I know you were involved in how do we get rid of the sustainable growth rate, which was supposed to reduce costs by just cutting doctors every year if they went above, with the spending went above the rate of inflation. Didn't work at all. I was very involved in this. AAR was as well. And we got it done with really bipartisan support and created an incentive to have doctors engage in prospective, risk-based, risk-adjusted payment, and to use that payment to do just what you were talking about, is use money upfront earlier rather than treating the illness when it gets worse. Simply said, again, the health system is really not set up that way. So it really has been some success there. That's going to be up for renewal. There'll be some discussion about what changes might happen there. But I think you're seeing big programs like Medicare, Medicaid, and now even more employers are getting involved and saying, we've got to be able to get better care for our employees than we have. We can't just keep paying more. We can't just keep shifting more costs to our employees. We have to find a way to use these dollars and get more value out of these dollars for our business, for our government, and for people who pay large co-pays, which is really a real problem for many, many people. So I'll stop there, and Gail will want to. So I think we build on what we learned, is what I'm saying, and
Very
our
good.
experience over the last 20 years, which has really changed things.
Let
Go
me
ahead,
let me make a point that I think has gotten lost here, which is that it is not so much the focus on the demand side for healthcare that we are trying to push forward. There's been a lot of work that's been done, and a lot of congressional attention and other attention, policy attention, on the importance of the demand for the kind of plans that we have talked about. What we have tried to do that has gotten much less attention is focus on the actual delivery of care. And I think it's easy to let that get lost in the weeds because it doesn't have quite the appeal of, oh, this is what you're going to get as a consumer of healthcare. This is what the employer is going to do for you. But it is where, if you are going to actually have an impact, you need to focus, which is how is care delivered? That has changed much less than people understand. What consumers are offered, what employees are offered, has changed dramatically over what occurred, say, 50 years ago. Unfortunately, how physicians and hospitals are organized, especially physicians, the captains of the medical team in the world in which we live, is much less changed than people understand. Most physicians continue to be reimbursed by fee-for-service. Fee-for-service ultimately rewards more for more and more complex services, does not reward for keeping people healthy and allowing them to make the best use of the healthcare system they have. And unless that changes, we are not likely to see a change in delivery. So again, what we have tried to do with this emphasis about better care plans is talk about the processes of care that are being offered, how physicians and hospitals need to interact with each other. And that, unfortunately, has received far less attention and is also subject to a lot of pushback from the existing power structure, so to speak, which will see changes that it might not always regard as desirable. So to differentiate what we've done, it is to indicate that if you're really going to change healthcare as we know it in the United States, it's not enough to change what's offered to individuals and employees. You've got to change how the healthcare is organized and delivered. And that is the hope that the better care plans will do. It is not something that has happened. And yes, certification is an important part of it, but it is a much broader issue than just certifying which plans ought to get the good housekeeping seal of approval, so to speak.
Well said.
Very good. Those excellent points. Let me just follow up a bit on this question of the providers and interesting them getting them interested, maybe is a better way to say it, in this concept and participating in it. Maybe a friendly amendment idea for your next version of this. I mean, what if the process that was just discussed of trying to focus really on the delivery system was part of the certification? In other words, to be certified, you had to prove, in effect,
Right.
you could do these things as Dr. Wilensky was just describing it. But then further, if you did get certified, you maybe were sort of on the fast track for both Medicare and Medicaid. In other words, what's the reward on the other end for the folks who go through the trouble of building these systems, which take investments, as both of you know? What do they get on the other end? It seems to me we ought to be offering them maybe less regulation through the other things that are going on out there. There's lots of, as you know, boards and quality measures, and to be an ACO, you got to jump through a lot of hoops and many other things, insurance regulation at the state level and the federal level. What if there was sort of a reward, you know, that if you became a certified entity, you know, an entity was set up, they said you qualify, sort of what do you get for it, so to speak? I'm thinking Medicare and Medicaid contracting, that they become part of the public programs a little bit more automatically or something like that.
I think it's a great idea.
Throw that out as an idea. What do you think of it?
Great. It's a really good idea. I think the whole emphasis on trying to reward those groups that are organizing and providing the kind of healthcare that makes sense to us has been important. We have long hoped we would be able to see it and make use of showing the differences in health outcomes that are provided. That has turned out to be very challenging, even in this age of sophisticated information systems. But doing something so that you actively reward, either in terms of how employers offer healthcare or how the government offers the options through Medicare or Medicaid, which, as you now know, is over 50% of the healthcare spend, would give a reward to the groups that are behaving in ways that we've suggested, focus on better care processing, and not just trying to do it through the demand for healthcare. That's where most of our focus has been in these last 50 years. That was an easier way to start, but I think many of us have realized we need to spend more time on articulating the kinds of changes in the delivery of healthcare that we think are important, and rewarding those groups that get it right by having increased availability in the Medicare or Medicaid offerings that the federal government uses. I found it a mystery as to why more people don't, as employees, don't demand and insist on options like the Better Care Plan. They really don't exist in many parts of the country in the kind of numbers that you would think. I'm somewhat biased in this issue. I've been now for the last 12 years on the board of directors of the Geisinger health system. It represents the kind of program, along with the Kaisers and Intermountain Healthcare and other groups out there, that meet the objectives that we have outlined. But in many parts of the country, including in the nation's capital, it's hard to get access to these as options. Not impossible, but hard. And in many parts of the country, impossible.
Congressman Schwartz, I think you were trying to get in, maybe say.
Yeah, no, it's a really good explanation. I guess I would add that also physicians' work has changed dramatically in terms of there are fewer and fewer solo practitioners or small groups. They're increasingly employed by actually either health systems, they're employees of the health system, and that health system tends to be based around big hospitals, and so it's really, some are also, one of the larger employers is insurance companies are buying up physician groups as well, and creating these opportunities for doctors to work together in a different way. So I think there are two things that have to happen. I think big health systems, big hospitals have to, and they're already trying to do it, but it's slow. Look, I live in Philadelphia. We have major academic health centers, you know, and they are used to operating as bring the patients to us, bring the patients to us. Now realizing that more and more they are being pushed to move to outpatient. And there are things we could do further to encourage that, to do more outpatient care, make it cheaper. You know, don't just do outpatient care and charge hospital prices, but do outpatient care that would be less expensive for the payers, including patients. And I think that many physicians are responding in a positive way. Certainly primary care physicians are, because they are not paid as well as all the other physicians. So being salaried, being able to get bonuses not based on RVUs, but based on whether they're meeting quality standards is very different, and in some ways much more rewarding, that they get to work in a team. So they don't just do, as I suggested, you know, refer somebody and hope they get the care for other services, but actually do something about it. We've talked about that in terms of mental health, you know, being able to have more mental health counselors available, or addiction counselors available. I mean, primary care physicians cannot do all of this alone. They need to be able to build a team. The only way you have the money to do that is in a prospective payment system, particularly if it's risk adjusted. So it's, I think the opportunity is there. I do worry about the fight that will happen. What happens is when things get tight in hospitals and doctors ask for more fee-for-service payments, we intentionally made fee-for-service less attractive than these prospective payments in macro. That was intentional. It was, if we keep increasing fee-for-service, particularly increasing fee-for-service for subspecialists, you know, not more for primary care, you're not going to get the results that we're talking about. So Gail's absolutely right. This is about the delivery of care. This is about what patients will see and feel and experience in improved outcomes. Improved outcomes, which means people will be healthier, also means we'll spend less at some point. You know, it won't have the same growth in spending that we've been seeing over some years. We hope for that. We expect that to happen if people are healthier. So I'm looking at the long game. It's not going to be easy to change our healthcare systems to do this, but we are seeing excitement in that area. But we need to keep having payment be able to incentivize these behaviors. Without those changes, it's not going to happen.
Yeah, that's been obvious now for a long time. I think that's correct. Let me just turn to a couple of there are a couple of questions from our audience that have come in that kind of match up with questions I was going to ask anyway. So let's do those, a couple of them. One being that, you know, a predicate of the plan is, you know, managed care generally is population-based capitation per month, per member per month kind of payments to try to get the right incentives, as was just discussed. But of course, that also carries with it some controversies around things that are going on in the news and today in the Medicare Advantage market for the last, you know, number of years. People worry that there's questions of risk and coding. What do you try to do in your plan to deal with those kinds of questions that might come up if you move even more of our system into capitated payments?
I'm not sure that in the plan specifics we have focused on that level of detail, but many of us in the group, including Congresswoman Schwartz, but others in the group have focused this on other aspects of our professional lives. And that is trying to make sure that there is sunlight, so to speak, on what is going on, putting information out in an available way about quality outcomes and about such basic measures as mortality and readmissions, et cetera, but making sure that the information focus is out there, allowing people to vote with their feet so that on a regularized basis, once a year, once every other year, whatever period is regarded as appropriate, people who are in a plan have a way of indicating their continued satisfaction or not with the plan that they're in. Those are really the ways to try to respond, better information, and the ability for people who are affected to be able to show their pleasure or displeasure is the way to have sunshine on these plans. It is hearing anecdotal evidence without any way to put it in context that is so frustrating. And in the MA plans, I think that's been particularly true. What the media tends to look at is what is being reported on MA plans completely out of context about what exists either comparably or on the flip side in the Medicare fee-for-service, which has almost no quality metrics compared to what we've had available for decades now in MA. And that's really the question for individuals, is what makes better sense for them in terms of delivery, and what do we know about the health outcomes that are associated with that? That's what's missing. Anecdotal horror stories of this happened, that happened, with no indication about did it actually matter. Some of the things that they're reporting on, they may not be desirable. And if you're affected, you may show your displeasure by moving to a different Medicare plan, the next open enrollment, which of course we are now in, as we are in every October to December period. That's good, and as it should be. But what do we know about whether it was important and really reflective of MA plans? We can't expect the media to put that kind of perspective out. There's no reason the plans and the government in particular can't put that kind of information out readily available to seniors and their advisors.
Congresswoman Schwartz, did you want to respond to that?
I would just add something else. I'm skirting this issue. Our paper did not speak very directly to spending and cost. We talk about, we refer to it. We could do that. We can think that's a follow-up paper potentially. But of course, if you're in the employer market, basically you're saying, this is how much money I have. What can I get for it? And there's no reason why somebody who's not in, as their industry is not, no healthcare, is going to know, how do I get better value for my dollar, unless we help them. So I think that's, part of it is, I saw it in the retiree program for Medicare Advantage. You get a retiree program for Medicare Advantage could help, be the option for retirees for large employers. It's been very successful in saving the employer money, in guaranteeing that the beneficiary who's now a retiree gets their coverage. So we have examples of how you could do this by providing more information and more options. But I will also say that there were tools built into Medicare Advantage that could be built in to other programs more broadly, which is, we don't let insurers make more profit than we allow. It's called a medical loss ratio. It's capped in terms of what they can make as a profit. If that's not the right amount, policymakers want to change it slightly, that's a conversation. They set the benchmark, which is what they bid against, and they bid, create their premiums around, and what the government gets to keep of the savings and what they have to use savings for are all dictated by regulation. We need to tweak any of that, we should. But Gail's absolutely right. We should be looking at comparison about where are we getting the best value now between managed care programs and fee-for-service. You rarely see the comparison in some of these reports. We don't like, what is the disenrollment in fee-for-service? What's versus an MA? It's not that different, actually. When they say, oh my goodness, there's so much disenrollment. Is there a reason why there's disenrollment when you go to a nursing home from MA? It's because you have to disenroll and go back to fee-for-service. No one mentions that when there's a report about that, which is kind of stunning to me. Actually, I think that rules should change. You should be able to stay in your Medicare Advantage plan if you want to, but you should be able to do either. So there are things to do. No one really even mentions cost comparison always between fee-for-service and a supplemental benefit, usually known as a Medigap program, because it doesn't cover all your fees for services for physicians. Often, many of the beneficiaries who can afford it buy a Medigap policy because we don't cover those benefits. So comparing where's there's waste, where's there's efficiency really matters. And of course, I would say, as a good Democrat I am, you need accountability. So you need accountability. The government needs to be a watchdog in public programs and needs to make sure that we are getting the value for our dollar. And more broadly, I think all of us should be calling for more efficient, more effective, more patient-centered care. And not only when you have an acute episode of need in healthcare, but during your whole life cycle, and particularly when you have chronic conditions that need to be managed, multiple chronic conditions need to be managed. That's awfully hard and awfully expensive for individual beneficiaries. We need the system to do better at monitoring that and making it more cost effective for the government or for employers who pay for it, and for beneficiaries who are taking a big hit on copays. So
Great.
I think we have some of the answers on this, is sort of what I'm saying. And we should use those tools. And of course, more transparency about price is helpful. I think it's not the total answer. So let's use some of those tools. Let's use it more broadly and make sure consumers have some information about this so they can make the right choices for themselves.
Very good. Well, we went past time, but I can't close this out, I don't think, without asking one final question, which is, since we had a little technical break, we'll go one more minute long past our time. But the final question I have for you really is something also that came in from the audience, which is about politics. One of our guests is a former Democratic Congresswoman, participated in the political process for many years through that perspective, and then Dr. Wilensky, served in a Republican administration, and I think probably there were diversity of political views amongst your multiple authors on your paper. Is a bipartisan approach to some of these big questions in healthcare advisable? Probably, from your perspective, it is, if it can be achieved, and B, how does that fit with our current political climate? Is it something that can be achieved given where we are, in our politics in our country?
Well, yes, I'll start, but I'll say it's tough going right now to find a way in the near future to get that kind of bipartisan support and be able to get it through both the House and the Senate and have it signed by the president. However, we have seen, even in this really challenging time politically, to move ahead on almost anything, you see bipartisan efforts in the Senate in terms of mental health and behavioral health, attention to maternal and child health being a huge issue. The disparities are enormous and need to be addressed. So you do see conversations about this. We've seen some bipartisan efforts, even though most of it hasn't, around, Part D, and the prescriptions and the cost of prescriptions, and how can we get all the medications we want, but can make it affordable for people. So I think there is really there is some conversation going on even now about these key issues. So I don't think you can be a politician without being both a pragmatist and an optimist. So I will throw those two together and say, we have to figure this out. Otherwise, spending is out of control. I'm a moderate Democrat. I believe that we should pay for what we spend. I do think we should get, bang for our buck for taxpayers. At the same time, I believe very strongly that healthcare takes government intervention. As Gail said, half of the people are on government programs in our country. So government has a lot to say about this. So it's the obligation and responsibility of current members and future members of Congress and future presidents to work this out and figure out how to actually do this well. And again, as a moderate Democrat, I believe that the private sector has a role in this. They can take action now, as we've talked about, to get on the bandwagon and do managed care well, and to take advantage of some of the tools that are out there to achieve some of these goals.
Thank you. Dr. Wilensky, you get the last word, Dr. Wilensky.
I'll try and make it quick. We are going to be approaching the general time period when it is slightly more likely that we could see some kind of bipartisan health reform in areas like what we've been speaking about in Medicare. And that is in the first year, year and a half after a national election, presents the most likely time to be able to draw individuals from both parties and from different wings of the parties together to try to push forward a solution. It is challenging. These are areas in which there are big differences in the parties between the role of government and the role of the private sector, and how much individuals ought to be able to make significant choices that affect their own well-being, and how much they should be, quote unquote, protected by the government against making mistakes in those decisions. But we will be coming up again soon in this most favorable period. We need to do something to make Medicare a better functioning program. Throughout this decade that we're in, we will double the number of people who are over the age of 65. It will have a big impact on the delivery of healthcare, on the cost of delivering healthcare, and of the well-being of an increasing segment of the U.S. population. Let's not screw it up.
Well, that will have to be the final word. Thanks to you both. I apologize to our audience for the technical problem we had earlier, but also for running a little late. But it was important, I think, to cover all these important topics as fully as we could. Big thank you to the two guests, national leaders in healthcare policy for a number of years. Thank you for coming and participating in this event. So thank you to all. We'll go ahead and close our event at this point. Thank you.